All right, good afternoon. We'll call to order the Green Mountain Care Board's hearing of November 19th. We have a draft proposed revision to Green Mountain Care Board Rule 3, the hospital budget review rule, and a potential vote noticed. And our staff attorney, Mark Henksler, will present that. I'd like to take up the minutes from November 5th, 2025, and I move for approval of the minutes.
So moved.
I'll second then, and all in favor say aye.
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 Aye, minutes are approved. Mr. Henksler, are you here?
Good afternoon, everybody. I am going to pull up a brief slide deck to walk you through what we got, and then happy to take any questions. Just give me a moment to pull this up. All right. Thanks for giving me a moment there. Is that visible?
Yes.
Perfect. Okay. So today we're going to talk about the draft proposed revision to GMCB Rule 3, which is the hospital budget review rule. As a reminder, we presented on this on November 5th after opening up a public comment period that began on November 3rd. And I'm going to just do a little bit of background, which is partially a repeat of what we chatted about a couple weeks ago, and then I'll show you a few slight revisions that staff are proposing here. So as a starting point, why is it that we are considering a revision to Rule 3? The original Rule 3, which is the current rule, was adopted in 2013, and that 2013 rule has been what we've been operating on since. There have been some minor amendments to the board's budget review authorities or duties and statutes since 2013, but no amendments that were sufficient to require revision to the rule. Last year, however, we had some significant statutory amendments to the board's budget review authority. And those amendments were in part in Act 49, in Act 62, and I think most substantively in Act 68. So taken together, those changes to statute make it most reasonable to consider rule revision here. What we've done is we've tried to capture some of the new statutory requirements in this rule so that the rule matches what's in statute. We've also made some what I consider quality of life changes, and we've done a number of things to codify parts of the board's process that have existed for some time in the rule, just to make this as clear, as transparent as possible. We went in detail over those changes at the November 5th board meeting, and the slides are on the website if anybody wants to take a look at those. With that, there are some changes we're going to talk about today, but I'll just point to two parts of our website. First, the draft proposed rule as it was presented on November 5th is accessible by the link that's right there. There's both a clean version of that document and a marked up version. The marked up version compares the November 5th draft of the revised rule to the current GMCB Rule 3. So you can see the differences between current and revised. And then the second item is the draft proposed rule that we're discussing today that has some minor revisions to it, which I'm going to go over. You can look at that document at the second link, and that one has track changes that refer back to the November 5th document. And those are just a few minor changes. And then for timeline, just a little background here. Open a public comment period on the 3rd, presented on the 5th. The public comment period closed on November 17th, and we have a potential vote today for the draft proposed rule. If there's a need to conduct a board executive session to talk about any attorney-client communication, we can do that today. If there's public comment that we want to talk about or address today, we can do that as well. But the value of a board vote today is that it will keep staff very much on track for going through the rulemaking process and providing sufficient time for the effective date of the rule to line up with the time it takes to do rulemaking. With that, we do have one small revision that I just pointed out here, but I'll talk about again in a few slides, which is that what we're currently recommending and aiming for is a June 15th proposed effective date for the revised GMCB Rule 3. With that, I'll turn to public comment. Again, public comment period from the 3rd to the 17th. We received 2 public comments, including one from the Hospital Association. The HCA communicated on the 5th that it had no comments and supported the revision. I just added that in there because the HCA's intersection with the board's budget review statute is a bit more particular, so I wanted to flag that. One of the comments that we received addressed the need to mandate hospital provision of essential services. That comment is on the website. I just want to point out one detail, which is that this rule does not cover the board's process for examining or reviewing service reductions or eliminations. That process is in the board's interim notice of service reduction policy. And I recognize that's a little different than an affirmative mandate for provision of hospital services, but just to state that that's where the board's current work on hospital service reductions is taking place, is in that policy. And then there were a number of comments in the Hospital Association's public comment, a number of recommendations in there. And I think the 3 items I'm going to talk about all refer back to the Hospital Association comments. So item 1 is a proposed change that staff are making to section 3.102 of the rule. This is the section that identifies the purpose for and the scope of the rule. And the 11.5 version of the rule actually points to and references the board's process for evaluating proposed service reductions or eliminations. That was a staff error. That was a me error. Initially, that language was in this rule because we weren't sure if that was going to go in the rule or in the policy. It's in the policy. So what we've done in the current version of the rule that the board is looking at today is we just took that reference out because, again, there's nothing in the rule that deals with the board's process for examining hospital service reductions or eliminations. So that's a pretty simple one, and we appreciate the comment from the Hospital Association to flag that error. Item 2, staff are recommending a change to section 3.203. This is the section that describes the board's process for setting benchmarks. The November 5th version of the rule states that before setting benchmarks, the board will obtain input from hospitals and the Office of the Healthcare Advocate on or before February 15th of each year. Public comment expressed concern that the board might only ask for input from a few hospitals or 2 hospitals under that language rather than all hospitals. So what we've done is we've revised hospitals to all hospitals to make it clear that the board will reach out to all hospitals to share benchmark information before voting on guidance. Staff also revised the words obtain input to solicit input. It's a small item, but just to that some hospitals might not choose to provide input, but what the board will do is solicit input from all hospitals and the Office of the Healthcare Advocate. So that's change 2. And then we got one more, which is change 3. This is in reference to section 3.504. This section states the proposed effective date for the revised rule. This is what we were just chatting about earlier. The 11.5 version states that the rule will take effect on July 1st. We received public comment that expressed concern that July 1st is the same date that hospitals submit FY27 budgets. As I understood the comment, there was some concern about the confusion that could arise from having the proposed rule take effect on the date that hospitals are submitting their FY27 budgets. So for the sake of clarity, staff are recommending a minor change to make the effective date of the rule not July 1st, but June 15th. Would clarify that the rule takes effect before hospitals submit their FY27 budgets. And I think we went over this last board meeting, but I'll just flag it again. What this means in practice is that the GMCB in March will establish FY27 benchmarks and guidance documents consistent with the current GMCB Rule 3. So that process will occur as it has in prior years under the current rule. The board's review of hospital budgets and everything that comes after July 1st will happen under the new rule if this rule is this proposed rule is approved by the board and we go through rulemaking and we have that effective date of June 15th. So those are the three changes that staff have recommended to the document since November 5th. And again, those are incorporated in the version of the document that is on the included with the agenda for today's public meeting. So we have proposed motion language here, but Chair Foster, I'll turn it back to you.
Thank you. Before we take proposed motion language, I just wanted to open it up to board member discussion and then also public comments. So I'll just start with the board. Okay, hearing none. I'll turn to public comment. I see Ms. Green from the Hospital Association raised her hand. And Ms. Green, if you don't mind, I actually have one question for you. There was language in the rule regarding providing information to the state auditor. The state auditor requests information to us. And I just wanted to make sure I understood the Hospital Association's concern on that. If you can address that in your comments, it'd be helpful.
Sure. Thank you, Chair Foster. Devin Green with the Vermont Association of Hospitals and Health Systems. First, I'd just like to thank Attorney Hexler on the process. This is a big rule and complicated, and really appreciate the opportunity to provide input. And I'll just start off with the auditor and other state agencies piece, and maybe sort of direct the question back to the Green Mountain Care Board, which is, what is the statutory authority for sharing the confidential information?
Why don't we hear your comments first and we can respond to that. I'm not sure if it's a statutory issue or an issue of what do we do when the auditor requests the information from us, because there's a distinction between confidential information and actually what we have to give to the auditor. So I think that was, I don't want to speak for the staff, but I think that was what we were getting at, is a concern of our obligations to respond.
Sure, and I think our concern is there has been legislation to broaden the information that the auditor receives, and that legislation has not been passed. And so we don't see the statutory or legislative authority that would provide confidential information of private entities to the auditor. And there has been a case around this sort of information and a holding of not sharing that information unless provided by legislation.
So I guess the question though, doesn't the auditor have the authority under their current legislation to request information from us?
They do, and the auditor would ostensibly be auditing you. So it's unclear to me why you would need to provide the auditor with confidential information in its audit of the Green Mountain Care Board.
Well, I think the issue would be an audit of us, but also an audit of what we're doing with hospital budgets, presumably. I mean, I don't know if this is a live issue. To my knowledge, it's not. But certainly there's a lot of state Medicaid dollars that are in the budgets that we approve and review. So how would we tell the auditor, no, we can't give you this information, it was provided confidentially?
I mean, we could go back to the Supreme Court case. Again, the holding there was not to provide the information unless directed by the legislature.
Wasn't that a question of subpoena power of the auditor?
I believe it was, yes.
Is that not a meaningful distinction?
I guess I'm trying to it would be helpful if you explained to me the distinction.
Well, I think the holding of the case, as I recall it, and I haven't read it in a couple of years, was that the auditor didn't have subpoena power to subpoena One Care Vermont, that his subpoena authority didn't go there, which is a distinction as to us because we do think that he can audit us. So the holding of the case wouldn't seem applicable here.
Yes, but in auditing you, I don't see the need to provide confidential information to the auditor. Again, this is confidential information from private entities for state functions.
Private entities that take a lot of Medicaid money, which is state money, and if they're auditing us, wouldn't they need to understand some of that information to audit us?
Again, they're still, despite the fact that they are getting paid by Medicaid, they are still private entities.
Right. I guess what I'm just trying to understand is how do we tell the auditor, no, we can't give it to you?
And I guess I'm unclear what confidential information is the auditor, what Medicaid information is the auditor going to be asking about that's confidential?
I don't know. It doesn't seem to be a live issue to me. Okay. All right. Well, I think I understand. And I appreciate you answering the questions. I think you had other questions and I started with that, or other comments, and I started with that one.
Sure, thank you. So the other comments are, and some of these are really just sort of process based. We really appreciate the Green Mountain Care Board trying to streamline the process and update it to current practices. So thank you for that. And also thank you in the hospital exemption process, making that clear. I think it would be really helpful to also make clear that the guidance is finalized by the end of March. This would be very helpful in hospitals putting together their budgets, getting ready for the budget process, knowing what the benchmarks and indicators are, and working from there without having anything shift under their feet would be really helpful. So if the rule could clarify that the guidance would be finalized by the end of March, I think that would help streamline the process even further. Similarly, if there was a date certain for the end of year review, I think that would be helpful as well. In the past, it's been in the springtime, I think in April. Recently, it's been at the same time as hospital budgets. If we could put a stake in the ground for when that process will happen, I think it will help everyone plan a little bit better for that process. I think the other piece we'd like to address is the mid-year budget review and just get a sense of how that's going to work. Our understanding is it's based off of the sort of significant deviation piece, and it's a little bit confusing because the definition of significant deviation is based off of the closeout of the previous year's budget. So how is this going to work when you're looking at the budget mid-year? And then how is it also going to work in terms of significant deviation when the budgets of hospitals really have a seasonality to them and really fluctuate throughout the year? And so could be extremely over budget, in March after flu season and COVID or something like that, and then go way down in the summer as things go quiet and sort of balance out. So wanted to get a better sense of that mid-year review piece as well. And then I also think for developing the the hospital guidance. I really appreciate you putting solicit input from all hospitals. I actually would, I would like that to be changed to obtain input from all hospitals, just so that we know hospitals gave input. I understand what you're saying with solicit. And maybe a way to ensure that you're getting input from hospitals is to reinstate VAS into this process. I know in my suggestion, I said have all hospitals or have VAS still in there, but in thinking about it more, I do think there is a power dynamic between the regulated and the regulator. And sometimes it helps to have VAS there as a organization that can provide candid feedback when sometimes the regulated can be unsure about how their feedback may be taken. So I think VAS could be a help there, and I would certainly advocate for us to be reinstated. And then finally, I do think it would be helpful to use this as a opportunity to instate an interim appeals process as required by 18 VSA 9381. That statute says that, you know, the Green Mountain Care Board is to develop processes around final orders. I know we have a loose process regarding hospital budget orders, but I think this provides us with an opportunity to really set out what that process looks like and have a clear interim process. So there's not a need for so much Supreme Court activity. And then for the effective date piece, I just wanted to clarify, it was less the fact that it was July 1st that this was going into effect, but more that we would be developing our budgets under the old rules and then presenting and having our budgets finalized under the new rules. And is there a way that we can avoid that sort of bifurcation of rules, which adds some confusion to the process? And that's all I have. Thank you.
Great, thank you. So in our, we have this potential motion before us. There's timing issues. I think with regard to this auditor issue, it's also important to note one distinction, which is the confidentiality is just exempts it from public inspection. So there's a question also, I think in my mind at least, whether or not the auditor is public inspection. So Ms. Green, I've asked you this kind of on the fly, and I appreciate you responding and giving me the information. But if you'd like to provide more information on that, of one, how would we tell the auditor, no, we're not going to respond, and what's our authority to do that? And then two, this issue of the distinction between exempt from public inspection and turning over in response to an auditor's request would be helpful. As I understand the rulemaking process, which I don't think I've ever actually been through at the Green Mountain Care Board, there will be time throughout the process for us to make other adjustments. So I think if we move now, we still will have the chance to get that feedback and consider it. And Mr. Henksler, Ms. Green had a number of issues. I think some of them maybe warrant in a response, and I'll just turn it to you if you have any information you'd like to provide.
Yeah, I'm happy to do so. At minimum, for the sake of keeping a kind of an open channel of communication here. I was listening intently, and I'll do my best to go in order of I think the points. But if I missed one, tell me. So starting point is the guidance deadline. I think that was the first one that I heard of March 31st. You're correct. The revised rule states that benchmarks will be provided in guidance by March 31st, and also addresses the fact that the guidance document may be adjusted, or there may be changes to the guidance document after the March 31st date. I'll start with practice. In practice, this is what the process looked like this last year. I know for certain. We have a change log that accompanied the guidance document, and I believe that change log is still on the FY26 guidance board page, and it details minor revisions to guidance documents that were made after March 31st. that changelog practice is consistent with VAPA, and was I think valuable to both the board and to hospitals in that it allowed for staff to address problems that hospitals identified in certain worksheets that need to be filled out, and it allowed staff to make other minor adjustments when issues surfaced in what is a relatively complex information exchange. So the goal is under this rule is for guidance documents to be issued by March 31st. That's the requirement. And then for those minor changes to be able to occur and be accompanied with a change log. I think the next item I heard was about the enforcement timeline. Yes, I'll say now that staff are beginning to work on process for next year and are happy to get input from the hospitals on timeline. I think we have some ideas on how to make this better going forward for everybody. But adding dates into the rule at this stage seemed premature before we've actually tested whether new dates for certain parts of the process work. Doing a revision later on to lock those into rule, that could be fine. I heard use of, I think I I'm sure I got this right. Use of the substantial deviation when reviewing mid-year budgets. Do I have that right? Okay. So I just want to walk through what's in the rule for clarity. Yes, a substantial deviation, or sorry, significant deviation is a deviation of end of year actuals from budget order, and you don't know end of year actuals until end of year and some months after that. So no argument there about having that information. The rule describes this process as follows. So first, there's a set time in the year when staff receive mid-year actuals from hospitals, and staff will be able to look at those mid-year actuals and compare them to the budget orders, and I think also look back at prior year performance to review some things like seasonality. I believe was one of the concerns that Vaz raised. Being able to do a mid-year review using some kind of attachment to the budget order seems necessary to carry out the authority in 18 VSA 9456 F2, which is the board's authority to make mid-year adjustments to price if necessary to ensure compliance with budget orders. That's a paraphrase. It might be slightly different than that in statute. So the process in the rule is that staff will inform hospitals of concerns if there's a mid-year concern, and then hospitals will have the opportunity to provide one of two items to the GMCB, either a corrective action plan, which would be the hospital saying, yes, it does look like we're running hot, here's our plan to deal with that, or two, an accounting of the hospital's budget performance to date and the reason that the hospital believes that it will not significantly deviate from its budget. So that check is an opportunity for the hospital to, for example, provide evidence of seasonality, evidence that there is likely to be a change in operations later in the year that lead the hospital to believe it's not going to significantly deviate from its budget. To do a mid-year, we need to rely on something for the mid-year. So that's the rationale in the rule there. I heard try to go in order here. The administrative appeals question that Vaz raised. So for the budget process, we have the board voting on budgets by September 15th and then issuing orders by October 1st. Those are both final actions of the board itself, not a lower entity like a hearing officer, for example, doing a recommendation order. So those are final actions and orders of the board. If Vaz or any other public commenter has proposals on additional steps that could be valuable to the process, we'd be happy to take those under advisement. I'm inclined to think those might be more worth more widespread consideration rather than segmenting them to one particular regulatory process that the board has. And then finally, I think I heard the confusion about the effective date. And I just want to clarify that the board's duties in statute in terms of what it reviews in hospital budgets are in statute currently. The rule is slightly off kilter from what is in statute. Statute obviously prevails, but aligning the rule with the statute ahead of the board's review of hospital budgets seems reasonable and valuable for clarity. I think I might have covered everything. If I missed something, let me know.
Thank you. I really appreciate that. I'll just add two things. One is completely understand when you need to make minor changes to the budget guidance. I would just ask that the benchmarks and indicators be finalized by March 31st and making that clear here. And then on the appeals piece, happy to submit something on that. But the law does state that that the Green Mountain Care Board shall adopt procedures for administrative appeals of its orders. And so that's where we're coming from there.
Great, thank you. I actually would like a little bit of legal counsel on an issue. So I'm sort of debating whether or not to make the motion and have the discussion first, or whether or not to go into executive session first. I think what I'll do is I will make the motion, see if there's a second, take public comment, then go into executive session, just because people come to observe the hearings and there's often not a lot of substance after the executive session. I don't like to make people wait. So I will make the motion. We will not vote on the motion until after executive session. I move to approve the draft proposed rule, GMCB Rule 3, Hospital Budget Review, including the changes discussed at the board's hearing of today, November 19th, the public meeting, as a revision of the current GMCB Rule 3, adopted on January 1, 2013. GMCB staff are authorized to proceed with rulemaking under the Vermont Administrative Procedures Act.
Second.
Any other board discussion on the present motion? And any other public comment on the proposed rule or present motion? Okay. Then I will make two additional motions so that we can see if we can go to executive session. I move to make a finding that premature general public knowledge of confidential attorney-client communications would clearly place the board at a substantial disadvantage.
Second.
All those in favor of the motion say aye.
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 Aye. The motion carries. I also move that we enter into executive session pursuant to 1 VSA 313 A1F for the purpose of discussing, for the purpose of seeking counsel from the Care Board's attorney staff. Attendance at the executive session will include the board members, counsel, and any necessary Green Mountain Care Board staff.
Second.
All in favor of the motion, say aye.
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 Aye, and the motion carries. There is a hand raised, so I might take that public comment before we go. Dr. Marifox?
Hello, everyone. Thank you so much. Can you hear me?
Yes.
Well, so much. I appreciate your time and the chance to do a public comment. I'm a pediatric hospitalist and general pediatrician in Rutland, Vermont. And I just wanted to thank everyone for the public comment period and just note what incredible outpouring of support there was due to the proposed reduction of services at Rutland Regional Medical Center. And I wanted to make sure that the board had the opportunity to see all of those comments and just note the breadth and variety of comments from everywhere from ED physicians to ED nurses to pediatric nurses to community care managers to pediatricians to family members and just concerned community members, and just make sure that you were able to see those, and just appreciate the time and our chance to weigh in on this decision. Thank you.
Yes, thanks, Dr. Marifox, for taking the time to be here, and to you and everyone else who has submitted really quite thoughtful and actually different public comments. Often we might get a large volume, but they're kind of repetitive. And I will say, in regards to this closure, they've been really quite thoughtful and intricate, and they've been impactful for sure. So I did want to acknowledge that we've received, it must be close to 300 at this point. There's many. I will ask maybe our executive director or Mark if we have any update on the process that we can share publicly. Is there anything we can share at this time on the process?
Defer to Mark on that one.
Yeah, absolutely. So just to give a little bit of a background, the Rutland Regional Medical Center notice of intent was provided on October 30th. Staff identified an item that was necessary to complete the notice. So the final date of completion for that notice was November 6th when it was submitted. And the GMCB responded to Rutland's notice with a request for a full submission under the interim notice of service reduction policy. And that was apologies for not having the date off the top of my head. I think that was November 14th. So Rutland is working on that full submission. We'll submit it. Once submitted, that will go on our website as a public document. The next steps will be scheduling of hearings, and those will be posted online once those are confirmed. I don't have the most recent information there, but that we have a web page. On our webpage, there's a notice of service reduction tab, and then under there are notices received, and any new information about that process gets posted to that part of the webpage.
Great. Thank you so much, Mark. And in addition to thanking all the people for public comment, our staff is working incredibly hard on this issue. There's been a lot of effort and back and forth to understand this thoroughly. And so I just wanted to thank Mark and our entire team for doing that. Ms. Marifox, Dr. Marifox.
Thank you so much. I really appreciate the update on the timeline. And then I also just want to draw the board's attention that our very incredibly skilled pediatric nurses have been told that they will no longer have a job as of December 21st. And so there is a time sensitive nature to this. And I appreciate all of your concerns and timeliness that you're responding to this, because if we lose those skilled nurses, we're not going to be able to do this whether we want to or not.
Great. Thank you for making that point. Aileen Chapin.
Oh. Hi, sorry. Can you hear me?
Yes.
Okay, I apologize. I don't usually do this. And I did hear you, Mark, that there will be other chances to speak, sounds like. But I'm actually calling you from the carport of Boston Children's, so I apologize if it's a little off kilter. But I did have some personal statements that I really wanted to let you guys hear based on the proposed closure of the pediatric unit at Rutland Regional, if you don't mind. I said, again, my name is Kayleen Chapin, and I am a parent and advocate from Pittsburgh, Vermont. And I am here today to speak firmly against the proposal to eliminate the pediatric inpatient unit at RRMC and replace it with 4 emergency rooms. The revision to the rule of reduction or elimination may look efficient on paper, but it doesn't reflect the lived experience of families in our community. Those of us who have needed the pediatric unit have never seen it unused, and every bed represents a child who needs care close to home, care that cannot be replaced by keeping children in the ER. Last year, they stated that 3,500 children were seen in RRMC's emergency department, yet only 250 were actually admitted. That number does not reflect a lack of need. It reflects a lack of pediatric consultation. My own son was seen recently and he has a chronic lung disease, tested triple positive for respiratory virus. was treated in the ER, but the pediatric physicians were never even consulted or called. That's not a utilization problem, that's a process problem. Transferring children to UVM and Dartmouth cannot be the default plan. In winter months, pediatric beds across the region fill up. We've all seen it. There's no guarantee of space, no guarantee of timely transport, and the burden falls entirely on us families, financially, emotionally, and medically. For many families, we drive an hour and a half. It's just inconvenient. It can be very dangerous. And replacing pediatric unit with ER beds is just not equivalent to the care that they would receive on their inpatient unit. ERs stabilize. They don't offer ongoing observation, child-specific medication management, respiratory support, and family-centered care that the specialized inpatient pediatric nurses provide. Closing this unit removes a critical safety net for our children during the seasons, especially when they need it most. Our community knows that. We've actually started a petition, and I'm just under 3,000 signatures on that petition as it continues to climb. And we are just simply asking for a pause, real community engagement, for transparent review of your data, and for creative alternatives such as like regional staffing partnerships or seasonal surge models, or eliminating local pediatric care. It's just not sustainable, and it's not what this community wants or needs. So please, we're just asking for that inpatient unit not to close, not to lose access, and for our kids to get the care that they deserve. Thank you.
Thank you very much, Ms. Chapin, and we appreciate you doing this while you're traveling and I presume seeing care, and I hope that everything goes safely and smoothly for your family and your trip. It's really valuable for us to have people take the time to be here. Any other public comment at this time? Okay. So we have an approved motion to go into executive session. We will do that. I'm going to guess that it will be short, probably be back by 2 o'clock. And then we have a pending motion on the proposed rule that we will take a vote on, I believe, after we come back from executive session. So we'll take a recess from this and return around 2 o'clock. Thank you. Okay, we can resume Care Board's public session of November 19th. We have a pending motion. I'll give people one more opportunity for any public comment via raise the hand. Okay, hearing none, then I will call for a vote on the motion before us. All those in favor, please say aye.
Aye. Aye.
Aye.
Aye. Member Holmes, I didn't hear you. Did you vote?
Yes. Aye.
Okay, aye. All right, then the motion carries unanimously and the draft proposed rules are approved. Thank you very much, Mark, and thank you very much to the Hospital Association for providing all the thoughtful feedback to us. Is there any other old or new business for the board? Okay, then I move to adjourn and I ask for a second.
Second.
All in favor, say aye.
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 Aye, we're adjourned. Have a nice afternoon.